Welcome to June's DEI Committee's presentation. It's my pleasure to introduce Dr. Elizabeth Betsy Collins. She is, let me pull this back up again, sorry. So Dr. Collins is both an MD and a Master of Public Health. She has come to us from Emory Midtown to talk with us today, where she also did her residency. She currently is an OBGYN. Her clinical interests are preventative medicine, healthy living through life changes, family planning, and reproductive justice and advocacy, decreasing maternal morbidity and mortality, breastfeeding and postpartum care. She is an advocate for the LGBTQIA patient population and continues to see a growing transgender patient base. Dr. Collins and I have had the pleasure of knowing each other since she started her residency at Midtown, and since that time we have worked together on both the Baby Friendly initiative at Emory Midtown. We have lectured together at the Emory Medical School, and I have been privileged to be a part of both of her daughters' births with her and her wife, Nicole. So yes, so that was a great pleasure for me. So it is my pleasure to introduce Betsy, and I am so glad that she was able to join us today. So please, a nice round of applause for her. Thank you.
Perfect. Thanks, everybody. I'll go ahead and take the slides up. So the first thing I just want to say is thank you for having me. It's a great pleasure to come out here. This is the first quote unquote face-to-face meeting I have had in 18 months, and it's just really nice to see people. And I think it's also really good to sort of get out of our comfort zones. And like Liesl says, I have been at Emory Midtown for almost 15 years now. So it's really nice to sort of get to some of the other campuses and talk to new groups of people, because I think it's very easy to sort of get settled in our little areas. And so this is a great opportunity for me. And June is also Pride Month, which is wonderful. And I sort of want to just give a shout out and a dedication to all the people who don't feel visible during Pride Month, but who would like to celebrate. So shout out to my bisexual colleagues and friends. And shout out to family members of LGBTQIA people, as well as spouses of LGBTQIA people. So we see you and recognize you, and join us in our celebration month. So our objectives today, Liesl reached out to me with some very sort of specific concerns. I think one of the things is just sort of awareness and understanding some of the needs of the LGBTQIA plus population. And this will be sort of a very general overview for everyone. So we won't cover everything, but I think that just an introduction is always super helpful, especially if this is not a patient population you deal with every day, or that you don't know that you deal with every day. We'll talk a little bit about some of the issues that these groups face when they're with us in the healthcare setting, how to recover when you have a mistake or a misstep, and some questions that are relevant when you're face-to-face with patients or working with patients, and how to adjust our care in a more gender-sensitive and sexuality-sensitive way. I don't have any financial disclosures, Emory. We always do this. So what does LGBTQIA plus mean? It means a lot of things, and it's becoming sort of a letter salad, so to speak. But you could sort of think about it as a catch-all for people who are non-cisgendered, meaning they don't necessarily identify with the sex that they were assigned at birth, and people who are not necessarily only interested in heterosexual relationships or sexual relationships. So we have people who are identified as lesbian, gay, transgender, bisexual or bigendered, queer or questioning, asexual, intersex, and non-gender binary, et cetera, et cetera. So this has been it's expansive and continuing to expand. So don't feel like you don't see yourself up there. It's not a big deal. I'm sure there'll be more letters later. And welcome to all the letters. So I always love this slide. That you could think of it as the genderbread person, or sort of how to talk about sexuality and gender identity, which are actually different things. So this is where a lot of confusion arises, that because of our letter salad, that we have so much going on in the LGBTQIA plus situation that people don't even know what we're talking about anymore. So let's start by talking about gender identity. So one of the very first things that we do when we're children is we start thinking about people in a gendered way. And anybody who's ever interacted with a 3 or 4-year-old will know that they're very demonstrative and specific about what a gender identity means. Oh, well, you have long hair and that means you're a girl, or you have short hair and that means you're a boy, or what are you? I can't tell what you are. And 3 and 4-year-olds are very sort of expressive about this because they're trying to figure out their own gender identity. But many of us will think of this as I or the people around me identify as a woman or a female person, a man or a male identified person, or maybe not either. So what we now refer to as gender queer or gender non-binary. So that has nothing to do with sexual attraction. It has to do with how you see yourself. Gender expression can sort of be a continuum of gender identity. So that is how you express yourself or present yourself. So, for example, I am a woman who tends to have androgynous or masculine appearing gender expression. Or I am a gender queer person with a feminine expression. So it's how we present ourselves. And there are men that may have feminine gender expression. There are women that may have feminine gender expression. These two things don't necessarily have to look or be anything. It's how the person identifies themselves. Then, and in the business of obstetrics, we talk a lot about biological sex. So this is essentially what genitals and chromosomes you had at birth. So when we are talking about patients, sometimes we'll say, this patient was assigned female at birth. That is that was the biological sex they were assigned, okay? So if you have a question about someone's biological sex, you can ask them, what was your sex assigned at birth? So that is a very specific question relating to genitals and chromosomes. And then, and again, that also can exist on a spectrum from sort of the female XX biological sex all the way through male XY, but there are some things in the middle. And then there's also people whose genitals don't necessarily match their chromosomes. I don't know if y'all are familiar with Jamie Lee Curtis, who's a famous actress. So she is a woman with a feminine gender expression. Her chromosomes are male. She has XY chromosomes. Her genitals, as far as I know, I have not seen them, are likely female, and her sexual orientation is whatever it is. Currently, I know she's married to a male. So a person who identifies as male. So that is an example of the spectrum of human existence, right? We have all of these different things interacting. And lastly, we'll talk about sexual orientation, which is who you are attracted to. So sometimes that includes no one. So there are people who are asexual. But here on this particular graphic, we have heterosexual, meaning hetero means opposite, so attracted to the opposite sex. Bisexual, both sexes or all sexes. Some people identify as pansexual. Pan is a better description for all instead of bisexual. And then homosexual, homo means same, so identifying as sexually attracted to people of the same sex. So why do we need to talk about this? A lot of it is that we're just not as familiar with some of the things that are going on. This is a rapidly changing language and visibility situation. This is not to say that being transgender or being homosexual or any of these things are new concepts, okay? These are not new concepts. What is new is visibility and acceptability and openness to talking about these things. So we need to adjust our language and our thinking to match those changing aspects of our culture. So I know that many of us have received very little formal education in this. You may never have attended a class or had anyone talk to you specifically about this. And that's why we're doing this. And hopefully as we do this more and more, your familiarity and fluency with this will improve. So we also have a patient population and colleagues that have different risks than cisgendered male appearing people. So, LGBTQIA people have traditionally experienced quite a bit of discrimination. And I'll go through some of those risk factors that are pertinent to this community. But we also want to recognize that and do better. So that's also why we're here, is because we want to improve the care that we provide. We also don't want to alienate our patients. So one of the things that's hard about being a patient is you actually have to go to seek out care, right? Most of us don't do house calls. Most of us don't just magically know when someone needs help. People have to come to us, and we want people to come in because delays in care mean that people come in sicker, they have less access to appropriate treatment and preventative health, and then there's less that we can do for them. So the last thing we want to do is alienate people. We want to provide good care, which when I trained meant the right patient, the right service at the right time, right? Which I think is pretty much still what we achieve, are going for. Patients also tend to have a lot of concerns about confidentiality. So no one wants to feel like a specimen or that their concerns are so unique and so out of the box that people are talking about them, or that they feel vulnerable or gossiped about. So I think it's super important that we talk about this in a HIPAA compliant and professional way, because that's how people should be treated. And that's what we're going for. In terms of visibility, so currently, and this is also rapidly changing, the most recent data we have is that about 5% of all people in the United States identify as LGBTQ. So just to put that in perspective, 2.5% of the American population identifies as Jewish. So I'm pretty sure most of us know somebody who's Jewish, right? That's a lot of people. 5% is twice that. So you all know somebody who is in this spectrum. Whether or not they've talked about it or whether or not they've disclosed it to you, every time we come to work, every time we call family members or go to a family reunion, we are interacting with LGBTQIA people. So in terms of professionalism, it's important to do the right thing, not only when you're in front of a patient, but it's also important to do the right thing when the patient's asleep in the operating room, when you're just standing there with your colleagues, when you're out of earshot of the patient, when you are in the elevator, when you're at dinner later on, right? Because the last thing that anyone wants to feel in our facilities is unsafe. And this is a matter of respect. So that's also why I'm here, is because it's just such a critical portion of our care. So I just want to address this category a little bit because it can be confusing. So more and more people are identifying as gender non-binary, meaning they don't feel like they fit specifically into a category of male or female. There's something else or something in the middle. Sometimes people use the terms genderqueer, agender, or bigender. Sometimes in Native communities, you may hear two-spirit. So they just don't fit neatly into a category. Oftentimes, people will use pronouns such as they, them as a singular, which is not easy for people who have not used they, them as singular. So it can be complicated, and it takes practice in order to sort of become fluent with using they, them as a singular pronoun. So I encourage everyone to just use they, them a lot, because the nice thing about they, them is it's inclusive, right? If someone has not disclosed to you what pronouns that they use and you want to be safe, they, them is always safe. They can correct you if they're like, oh no, I use he, him pronouns. Great, perfect. Then you're going to mirror that person's request. But if you want to sort of be neutral, they, them is always a good choice. Some people are using unique pronouns like Z, for example, which can be spelled XE, SIE, or ZE. And then if you're looking for an honorific that's gender neutral, mix instead of Mr. or Ms. is acceptable. This is not a new concept. Again, we see in Native communities, often is recognition of two-spirit or non-binary persons. And then in many cultures throughout the millennia, there have been people documented as identifying as non-binary. So this is not a new thing. But I will say I am seeing more and more and more patients identify as non-binary. So this is a rapidly expanding identity category, I would say, in terms of expression. Gender non-binary people may not look like anything. So you may look at someone who looks very gender binary to you, but they may use they, them pronouns or identify as non-binary. So just because somebody looks a certain way does not mean that that is how they identify. So this is a common sort of pitfall that I think a lot of people fall into, which is why talking to our patients, mirroring their language and asking what they like to be called is super important, because you can't look at someone and know. This is not the same as being intersex. So remember to our graphic about the genderbread person, being intersex means that you have genitals or anatomy and genes that don't fit the quote unquote standard definition of male or female, not the same. It can also be really hard for people who identify as non-binary to fit in a very binary society. So our society has made things so binary, you can hardly buy a bicycle without it being pink or blue, right? Think about girls' bikes and boys' bikes. Think about bathrooms. Think about showers. Like, when was the last time you went to a multi-gender bridal shower, right? Like, it is so hard to know where you fit when you are a non-binary person. This category didn't even exist when I was growing up. I would have loved to have known that this was a thing. And I can tell you, I often really struggle. Like, when I go out and go dress up nicely, I don't know which bathroom to use because I don't know which bathroom I'm going to feel safest in. So it can be very complicated. And I think we just sort of have to recognize and also really try hard to make things as gender neutral as possible, because then you're taking the guesswork out of it. Oh, it's not the men's room or the women's room, it's a bathroom, right? It's not a men's bike or a girl's bike, it's a bike, right? And so, in raising children, I'm trying to do that myself. It's not a princess dress, it's just a dress, right? It's not a boy's dress or a girl's dress, just a dress, right? Anyone can wear it, doesn't matter. So, really trying to think hard about how we, the spaces that we make and the safety of those spaces. When you are out somewhere and you see someone waiting in line to use the bathroom, they know which bathroom they're waiting for. You know what I mean? You don't have to remind them. So things like that are super important. So some of the special risks of this population are that a lot of people are underemployed, which can mean that they're underinsured, uninsured. They may have difficulty maintaining housing. They have higher rates of poverty and underemployment. There's also an increased risk of survival sex and physical trauma. So if you're unhoused and don't have a good job, unfortunately, sex work is accessible to a lot of people, but it's very unsafe. So a lot of people are putting themselves in harm's way because they have to. They're trying to get by. And that does increase their healthcare risks as well, because they're putting their health on the line. There is a lot of anxiety about interacting with the healthcare system. It is not unusual for me to walk into a room with a patient and then just sort of exhale their deep yoga breath and this was so much better than I thought it was going to be. And I'm like, great. But you can imagine every time the person comes to the hospital, it's not just, should I use the men's room or the women's room? It's like, should I be here at all? Right? So just opening a space and making a safe space for patients is super important. A lot of people delay care for all of these reasons, right? They may not have the money, they may not have insurance, they may be afraid, they may have been mistreated. So there's so many reasons, but making sure that we have appropriate outreach to patients, which I'm really hoping Emory will work on. We don't have a lot of public facing and patient facing material that is specific to this community. So I'm really working hard to see if we can improve that. A lot of patients receive incorrect or undesired services. So I have had plenty of friends who, looking back, probably identified as non-binary or maybe even transmasculine, who went to plastic surgery and wanted a breast reduction. And they would say to the surgeon, well, I want a really small chest. Like, I don't want to have the breast that I have currently. And the surgeon would argue with them and tell them that, well, they really needed a B or a C, and that they weren't going to do the surgery that the patient wanted. They were going to tell them how big they thought their breast or chest would be. And so, unfortunately, working primarily in the GYN-OB sphere, I see this a lot, even with my cisgendered female patients, people being told what they needed. And unfortunately, that's really not what we should be doing. We should be listening to our patients and trying to match our care with their goals. There is unfortunately an increased risk of untreated mental illness, trauma, and suicidality in this patient population. And it's not that mental illness is more prevalent, it's that it's less well treated. And people are also at risk, such high risk of trauma, and they just don't have access to the care that they need. There are some increased risks associated with sexual behaviors. There's earlier onset sexual activity in the LGBTQIA population. So that's why it's super important when we're talking about sexual education, especially with preteens and teens, that we're inclusive in our language and inclusive in our sexual spectrum conversations, because these kids oftentimes feel alienated and don't feel seen in discussions about men and women and heterosexual marriage and penis and vagina sex. And one thing I always like to stress anytime I'm talking pretty much about any subject is that nothing is perfectly safe, right? Like we could easily, you can blame people and say, well, you know, they're doing things that are unsafe, and you know that's their own fault that they're transgendered and they're doing sex work. This is not an issue of blame, okay? We have the society we have, and it could be better. Just like people are going to be human beings, are going to do things that are risky. Sex is risky, but sex can be safer. And that's what this is about. It's about making things better. It's not just recognizing that this is what it is. It could be better. So that's really what this talk is about. So one thing that came to my attention this year was something called the platinum rule. And I don't know if any of you have heard this before. I'm sure everyone's familiar with the golden rule, right? Treat others as you would like to be treated, which isn't good enough. We should treat others as they want to be treated, right? As they want, not what we think is best for them, what they think is best for them. And that is also what this is about. So switch your golden rule into the platinum rule, and this will be an excellent sort of life thing to carry forward. So one of the things we can do is really start with the very first things that the patients are interacting with. So intake forms, front desk, call center staff. And I have done these talks with all of these groups in the past. I'm absolutely sure we could be doing them more often. And I'm also happy to do outreach to any of these groups. If anyone has staff that they would like specific talks on this, I'm happy to do it. But it never hurts to ask, hey, what name do you like to be called? What pronouns do you use? How can I refer to you? And if they look confused, you can always say, like, do you like to be called she, her, or they, them? So giving examples sometimes helps patients, and really normalizing this stuff. And the normalization is what makes it doable. So when I'm taking a sexual history with a patient, I ask about lots of things. Sometimes people are confused and they look at me and they're like, well, I said I have a husband. And I'm like, well, that's fine. Does your husband have a penis? That's really all I want to know. I mean, that's great that you have a husband, but that can mean a lot of things these days, right? And so usually once you explain why you're asking the question, like, I just want to call you by the name you want to be called. It's not, you know, we do this for everybody. Then they're like, oh, okay, great. You want to call me by what I want to be called, right? I mean, nothing's worse than getting called the wrong name. So it's really important that patients know that this is a normalization of a behavior that we want to use with everybody. Relationship status is another sort of like weird question. We used to have all these forms that said like married, single, or divorced. Well, that doesn't really cover anything now, right? Like that means nothing. I never check a box that says married, single, or divorced anymore. I write who the patient is in a relationship with and what type of relationship is it. I have patients who are in asexual long-term relationships. They're not worried about pregnancy, they're asexual. But I know that they have good emotional support because they have a partner, right? So you have to be more descriptive. These words are outdated. So that's sort of how you have to think about things. What information do I want to know about this patient? Do I want to know, are they at risk of pregnancy? Do I want to know who they live with at home? Then ask that question, right? Instead of relying on, oh, well, they're married. That means that they're in a heterosexual relationship and they're definitely at risk of pregnancy. Avoid gender binaries as much as possible. So forms that are pink or blue, restrooms that are identified as male or female, just anything that sort of smacks of like, oh, you can only look like a person in a dress or only look like a person in pants. And also do the training that we're doing today. So working with people to change how they ask questions. So one of my friends called me after an experience with Emory Reproductive Center, and she had presented to the front desk, and they said, well, is your husband here to leave a sperm sample? And she was in a relationship with a person that did not produce sperm. And she was like, no. But right there in that one sentence, they managed to alienate that person and other them in front of a waiting room. So the correct way to answer that question would be, or to ask that question would be, do you have anyone with you that is leaving a sperm sample today? Right? That's what you want to know. You don't care about their relationship status. That doesn't matter. The question is someone coming here who's going to leave sperm for you? The other thing that you can do is look at the gendered nature of patient education forms. So in gynecology and obstetrics, we are not good at this. And this is something that we are really going to have to get better at. But using, again, specific language to describe what you want, right? So we used to see this term all the time. Well, don't have intercourse during your pregnancy. Well, what does that mean? I got questions from patients all the time. They had nothing to do with their sexuality or gender expression. Does that mean that I can't have oral sex? I don't know. Intercourse, what does intercourse even mean, right? It's not specific enough. Do I want to tell the patient not to place anything in their vagina, or do I want to tell them to avoid orgasm? What do you mean, right? So we need to get away from these terms that actually don't give the patients enough information. Avoiding terms like husband or wife, include non-contraceptive benefit information on forms. So some people get IUDs because they have heavy bleeding. It has nothing to do with whether or not they want to prevent a pregnancy. Some people take birth control pills because they are depressed before their periods start. And so they're just taking birth control pills for that, or contraceptive tablets, or as Dr. Hatcher used to say, ovarian cancer prevention pills. So there's lots of ways we can describe things that are not necessarily in a gendered way. And then also using inclusive imagery on your form. So things that patients that may not appear binary, things that are not heteronormative or even relationship based. Like sometimes it's just nice to see a parent with their baby and it's not a couple, because not everybody's in a couple, right? So increasing visibility for communities that feel unseen. And then also watch out for racially biased images as well. So these are all things that we're trying to improve on, because again, we want each other and our patients to feel at home here and seen here. So one of the things that I think increasingly we're going to see is people first language. So people first language avoids pathologizing and gendering language. So one of the things I've seen a lot in the literature is the term person with HIV. So instead of saying, hey, Joe is HIV positive or the patient is HIV positive, you say that he's a person with HIV or a person living with HIV. And it really makes them seem like a human being instead of a thing, right? Instead of saying inmates, you say people who are incarcerated, right? Instead of saying homeless, you say people who are unhoused. So this is happening, whether or not you've seen it, more and more, you will notice, especially in academic literature, that phrase, people with, people living with, person who uses IV drugs, so on and so forth. So this is really the standard in terms of language. And you can practice. So instead of saying he's a homosexual, you say person who has sex with men, or person who is attracted to men, if he is a man, right? Instead of saying she's an atheist, you would say she's a person who doesn't believe in God, right? Instead of saying they are a fireman, you would say they are a person who fights fires. So you just practice all the things that you normally do, flip it around. So this was a slide made by a colleague up in New York who does a lot of trans-specific care, but just examples of less gendered language in a lot of, and especially in GYNOB, we talk a lot about genitals. So these are some of the things that we are starting to use more and more. And this is a really great opportunity to talk about mirroring. So I may have mentioned it earlier, but mirroring is using the patient's language to describe their body. So oftentimes, for example, when I'm doing an exam, I'll touch the patient on the leg and let them know that I'm about to start their exam. And then I'll say, I'm going to touch the outside of your genitals, right? Not specific at all. Doesn't tell them anything about what genitals I think they have, because I don't know what language necessarily the patient uses for those areas. So it's never bad to start with something that's less gendered. And then if the patient says, oh, I've got this spot on my labia, you can say, yeah, that spot on your labia, that is the language that you use. So the Grady Gender Clinic, and this is thanks to the attendings down there that I was able to get this for today's talk, uses this as their intake form. So you can see here, this covers sex assigned at birth, a person's gender identity, but does not talk about who they're sexually active with. So this is really about how the patient sees themselves. It's not about their sexual history. It's not about who they're having sex with. So just an example for you all to see. And then I had previously made this sort of like check-in script or like patient-facing script. So if any of you want a copy, there's a few floating around. But it sort of leads you through how to ask these questions and how to approach a patient when you don't know what to say. So when I walk in a room and I don't know what someone's name is or don't know what their pronouns are, I immediately turn it on myself. Hey, I'm Betsy Collins. I'm your doctor today. I use she, her pronouns. What about you? And then the patient identifies themselves, and then I know right away what they would like to be called. And I don't think it's necessarily that different from having a nickname. Like I've had a nickname my whole life. Nobody calls me Elizabeth, even though I have to put it on all of my documents because that's my legal name. Nobody calls me Elizabeth. Everybody calls me Betsy. So when people call me Elizabeth, I'm like, they just don't know me very well, right? It's this sense of unfamiliarity and the sense of, you know, yes, that's what's on my birth certificate. That's fine. But by using the name that somebody goes by, you're really saying, hey, I see you, not just whatever's on this piece of paper. Sometimes patients are confused or don't know what to say, and that's okay too. You know, sometimes I'll ask patients about pronouns and they're like, oh, it's she, her, and they sort of seem a little like whatever, and that's fine, right? No harm has been done. And always remind people you can't tell by looking at someone what they like to be called. The other thing that's really nice is if you can denote anywhere that is possible what those chosen name and pronoun, what that information is, and make sure that if you're in a handoff situation, that you tell the next person. So one of the things that's always super frustrating is when somebody checks in at the front desk and gets the wrong name assigned or gets misgendered, and then that continues on through the patient's course, right? So then they move on to the next place and they get misgendered, and then they go to the next place, and then they're so exasperated by the time they actually see the provider that it's already been a pretty negative experience. So it's super helpful if you identify that a patient may use name and pronouns that are different or have any concerns about this, that you verbally connect with the next person. Like, oh, hey, this is Joe Smith. They're here for a pap smear and they use he, him pronouns, and you're handing off to the medical assistant who then knows to call patient Smith and confirm that they like to use the name Joe, or they use the name Joe, not like to, that is their name, and that they use he, him pronouns. You pull the patient back and the patient's like, that all went smoothly, right? So this is actually a patient of mine that had an experience about a month and a half ago that was pretty unfortunate and sort of really clouded the care that they received at my hospital. So I'm going to go ahead and just tell their story. The patient is transmasculine. So that means that they were assigned female at birth, but identify as male, and they have a uterus. So they presented for a gender affirming hysterectomy. So their reason for hysterectomy or diagnosis was gender dysphoria. And, you know, the patient showed up and was thrilled, like, oh, hey, I'm going to have the body that matches who I think I am, who I am inside. And they show up and the registration desk calls their name, you know, Jane Doe, please come up here. And Jane Doe stands up and is very masculine presenting, right? So how do you think in an open atrium registration area in the front of the hospital it would feel to stand up and immediately be misgendered and identified potentially as a trans person, right? Scary. This person said they felt afraid, right? So already we're off on the wrong foot. So the other thing is, I don't know if you guys have ever heard the term dead name, but dead name is to use the the name that the person was given at birth that they no longer use. So this patient in their complaint said, I was dead named, which sounds awful, right? Like it's an awful word. And so they went up to the desk, and then the front desk person didn't communicate anything about the patient's gender identity back to the back of house staff in the pre-op area. So the patient got all the way back to the back room and was still being referred to by their dead name, and had to correct every person that they ran into from there to the operating room, more or less. Then finally, the surgery started. I was there. The patient felt a little bit more safe. But the patient said the whole time that they were waiting for their surgery, what should have been an exciting time for them felt very negative. Like they were perseverating on the negative feelings about how their dead name kept getting brought up over and over and over again. And while I totally understand that we want to make sure that we have the right patient getting the right procedure at the right time, that shouldn't stop us from recognizing, just like when I meet somebody, I'm Elizabeth Collins. But if you want to talk to me, you call me Betsy, right? Because you're my friend and you know that. That is sort of that patient's experience, right? They knew what they were there for, but their name was not what they were being called. So then the patient had their surgery, which went fine. And the patient went to the post-operative area, and their nurse didn't talk to them. And the patient had a major surgery and went home the same day, which is standard procedure right now. But I can't necessarily read into why this happened. But the bottom line is that patient felt like they didn't get the care that they deserved because they were trans. And so I don't have any way to prove that that is or is not the case. But what I can say is that every patient deserves to get post-op instructions when they've had a major surgery. So we'll talk a little bit about how we dealt with this situation. So thankfully, the patient contacted us. That was the first thing, was that the patient felt safe to tell us that this happened. And we should always thank the patient when they let us know that our service was not up to standard. I was, again, very lucky to find out who the patient was and was able to contact the patient myself. I apologized. So say you're sorry when something bad happens to somebody. Doesn't mean that you are accepting responsibility for the way every single person behaved or every single thing that happened. But what you're saying was their experience was substandard, and that you personally are very sorry that that happened. And then I had the opportunity to brainstorm some improvement opportunities. So I'm actually giving this same talk to the perioperative staff at Midtown next week. So that was one of the opportunities that came out of this. I created gender neutral discharge instructions that I personally print and hand to the patient pre-operatively. So I know that they received them. And it gives them an opportunity to read through everything and ask questions and know what to expect. So while I am educating the perioperative staff, I also recognize that miscommunications can occur, right? Who better than the patient to hear it from me, what their postoperative experience should be like. And I've given it to them in writing. So those were all opportunities for me to improve and also to make sure that the patient experience was better. So just in summary, I want everyone to know you can do this. You shouldn't feel scared or worried that you're going to screw it up. We all have moments where we're like, oh, it didn't come out the way I would like it to. And it's okay to be like, sorry, I'm so sorry that I misgendered you, or I used the wrong name. What name can I use? What pronouns would you like me to use? And just start over again. We should all have a willingness to change and adapt. The only thing that is constant is change, correct? So we got to get better. It also recognizes our humility in this situation as providers. We don't know it all, right? We're here to get better at our jobs. Know how to apologize and not make excuses. I'm sorry this happened to you, period. Right? And this is applicable to many clinical scenarios. Patients expect us to be doing this. Whether or not, again, you think you may be interacting with LGBTQIA people in your life, they're there. And all of our expectations is that we have this level of competency. It's a safety issue. So I was listening to a talk, our grand rounds this morning was about bullying and intra-office, intra-hospital aggressions between nurses and doctors, providers in general. And one of the things that she pointed out in the talk was that when people are in negative interactions, that their performance declines. So you can imagine when I walk in the room and I see my perioperative nurse misgendering my patient, what's the first thing I'm going to do? I'm going to get mad, right? And I'm going to be standing there thinking to myself, this is a disaster. And then I'm thinking to myself, how am I going to fix this? And all of my thoughts suddenly are on this negative thing instead of focusing on the patient's perioperative safety, making sure that the consents are correct, that we're ready in the operating, all these other things, right? So this is a safety issue too. Right patient, right place, right time. It's a business issue. People have a choice, okay? These patients have money to spend and they can spend it anywhere. And if you mistreat people, they will not come here, right? And so that, I hate to be cold and calculating about it, but that's the truth. So if we want to have a role in this community and in any community, we need to be receptive and we need to be welcoming. So things you may see changing, you know, like I said, person first language in academic literature is very common. And you'll see it more and more. Bathroom labels, you may see non-gendered bathroom labels more and more. That's a very common thing. And that's certainly something we're trying to do with our clinic. Reproductive and plastics care have a huge gender diverse patient populations. So more and more, you may see patients coming in for mastectomies as for gender affirming chest surgeries. You'll see patients coming in for hysterectomies. You'll see patients coming in for fertility preservation because they're about to go through their transition and they want to bank sperm or eggs for their transition. Believe it or not, I've written whole book chapters on breast and chest feeding that are gender neutral and gender inclusive. So if I can write a book chapter on breast and chest feeding about gender with using gender inclusive language, I know I can talk about anything. So welcome to this big wide world of LGBTQIA healthcare interaction, but I sincerely hope that this has been helpful to everybody.